Okay, we're going live in five, four, three, two.
I'll press play. We'll just give a minute for everybody to join. Okay, welcome everybody for this week's Miami Global Brain Tumor Symposium. We're very excited because we have a special presentation this week. My name is Mike Ivan. I'm the director of the symposium, and I'm joined today by my co-directors from here at the University of Miami, Dr. Jacques Morcos, who's professor and chairman of our program, and also director of cerebrovascular and skull base. Also Ricardo Comatar, who's one of our professors and director of our residency program. He's director of our surgical neuro-oncology program and the UMBTI. And Carolina Benjamin, who's our newest recruit, assistant professor, brain tumor and skull-based specialist, and also the director of our Keynes lab. So this week we put on, every week we put on these symposiums. This is the 19th week. We've had tremendous success with over 5,000 views now ever since the beginning. And a lot of that is due to our fantastic team that occurs behind the scenes. So Christina, Roberto, Ingrid, and Ignacio, so many thanks to them for sending all the emails, doing all the artwork, and putting together these great symposiums. If anybody has any questions or about the symposiums or our department, you could always find us on social media or the web. We're on Twitter, Instagram, YouTube, as well as our website here. And please feel free to contact us for anything. In addition, we have kind of a matching symposium that happens on Thursdays, which is focused on cerebrovascular and skull base, run by my partner, Dr. Morcos. And tomorrow we have an exciting program talking about brainstem anatomy and brainstem cavernomas with Dr. Kadri and Dr. Hongo, who have phenomenal experience with these difficult lesions. So be sure to check that out tomorrow. Also, a quick teaser for next week on our symposium. Manish Aghi is going to be joining us from UCSF to talk about Cushing's disease and the approach for neurosurgeons. So make sure you tune in next Wednesday, same time, for that talk. Some housekeeping before we begin. To all participants, please ask your questions using the Q&A or the chat button. We encourage you to be as interactive as possible, and we'll try to get to all the questions before the end of the symposium. We don't offer CME, but you will get an email confirmation documenting your participation. And please be sure to like, follow, and share our videos. If you have to leave early or whatnot, these videos are recorded on YouTube, and you can check them out at a later date or check out all the other videos that are on there. There's really been some phenomenal talks. And if you've missed any, I encourage you to check them out. This week, we have a great list of panelists from across the country, starting out with Dr. Rodriguez. She's an assistant professor and director of the neurosurgical oncology program. She's a physician scientist and has her own lab at the University of Arkansas, where she focuses on brain tumors. With Brian Williams, who's an assistant professor of neurosurgery and director of the brain tumor program at the University of Louisville. He's also part of the restorative neuroscience department and a brain tumor and skull-based expert. He did his fellowship with Charlie Teo, who we just had a couple weeks ago. And Dr. Sarkis, he's a neurosurgical oncologist and brain tumor expert at Dignity Health in Bakersfield, California, and a past fellow from our program here at University of Miami. So thank you all panelists for joining, and I look forward to your cases. This week we have an outstanding speaker. Dr. Maldon is coming to us all the way from Brazil. He has over 25 years of neuro-oncology experience and is really world-renowned and recognized for his work done on awake brain tumors in neuro-oncology. He's given over 200 lectures around the world, has published thoroughly on the topic. He's also a visiting professor at the university at MD Anderson as well, and is really integrated into their program. He's Emeritus President of the Flank and founding president of the for Society of Neuro-Oncology in Latin America, or SNOLA. And so a tremendous effort that he's done so far in organizing neurosurgery in South America, and for that he should be really thanked. We're very, very excited about his talk today on management of metastasis. This is probably the most common thing that all neurosurgeons have to deal with, and I can't think of anyone better to give the talk. So thank you so much for joining us from Brazil.
Oh, thank you so much for this kind invitation, and congratulations for this great program that you guys are providing to us. It's a great honor to be part of it, and definitely you are helping the neuro-oncology all over with this solid and very interesting program. Just let me, especially I'd like to thank you, Ricardo, you, Michael, and Jack, for all this this kind of invitation. Let me share my screen. Okay.
Perfect.
Okay, good. So we're going to discuss the management of brain metastasis. You guys are going to see that this is very important. It's basically the most common non-primary tumor of CNS, and people are living more and more with cancer, and we have to deal somehow in their lives with a brain metastasis or adverse events related to it. So it's very interesting because we are seeing huge changes in paradigms and treatment options regarding this pathology. I have no disclosures for this presentation. And I always would like to start this kind of lecture with a simple but not so simple case. So if you have a patient, 38 years old, with a melanoma, diagnosed 7 months ago, and started with dizziness, headaches, and after doing this MRI, the oncologist put his on steroids. And you can see how many considerations we can do it based only with this clinic and the MRI. So how should we treat the brain? Is it important any molecular information? We know this is a melanoma, but is there something more that should be crucial for defining treatment and prognosis for these patients? And how should we stratify this melanoma patient? Is there any rule for whole brain radiation nowadays? Is this still a current solid treatment option? Surgery or radiosurgery for some specific lesions, and benefits of each of this kind of modalities. And how about steroids? We all know that steroids are our best friends in neurosurgery. We cannot live without steroids, at least in the peri-operative time of following these patients, but maybe this is not so good for some kind of patients, and how to deal with this new steroids concept. And let me put this down. So if you have any other histology, how should we deal with these patients? And now in oncology, name is important, but the surname is most important. And how should we deal with the surnames? And if all patients are immuno or target candidated, and this is definitely extremely important in our management. If this patient is not a melanoma, it's another somehow diagnosis, how all this consideration should be input, or maybe we should do another considerations for each histologist that can or may affect the CNS. So we're going to start with a brief overview of epidemiology, stratification, the molecular classification and clinic, and the role of surgery, the role of radiotherapy and radiosurgery, and finally the conclusions. I'm just would like to highlight that finally last year we have the first SNO meeting fully dedicated from brain metastasis that definitely I think people all over the world are looking more carefully for this disease. This is very important, and when we talk about people, I'm talking about the multidisciplinary team as well, the industry and pharmacological industry and technological industry, and so all investments to this pathology are related now as a good or current treatment and approach for this kind of disease. So when we talk about numbers, we know that 25% of cancer patients might develop a brain mets. People are living more and more. We have excellent treatment options for all kinds of cancers nowadays, and somehow your patient might develop during his disease, develop some brain mets or carcinomatosis. And we have an expectation of almost 200,000 people affected with this problem in the United States. This is by CBTR numbers. We know, and this is important, that some histologies has a high CNS neurotropism like melanoma, small cell lung cancer, renal cell, breast, and testiculars. And this is important as well, because basically this patient should be followed carefully since diagnosis until the whole course of follow-up with some CNS investigation. But all cancers can affect the CNS. So even like hair disease can affect the CNS, like prostate, ovarian, and thyroid. This is a very important issue because I just mentioned that we have a high number of patients affected by this disease. And when we look at PubMed and just type a brain met, we have over 20,000 publications. But when we put all this together in evidence-based medicine, we have just a few publications with level 1 recommendations. We are going to mention a lot of trends, but unfortunately, evidence-based medicine for this kind of disease is, so far is not as good as we expected. So many of these treatment trends we are going to discuss are based in retrospective analysis or meta-analysis or phase 2 studies. But when we talk about the traditional radiotherapy, surgical resection, radiosurgery, and chemotherapy, we have just a few good papers that recommend as a level 1 of recommendation to approach these patients. This is clearly when we look carefully to the incidence in United States in 2019. So brain metastasis is definitely are very common, pretty much like breast cancer and lung cancer. But when we look to the main congress in the world, in the oncology point of view, the ASCO, we have just a few abstracts regarding brain metastasis, and unfortunately when you go to clinicaltrial.com you can see just a few prospective studies going on and active prospective studies. So as I mentioned before, the pharmacological industry just they used to close their eyes to this pathology. If their patients has some brain metastasis, they used to not be included in clinical trials. But this is changing so far. We are going to discuss this. that probably CNS is the new good scientific target for research and pharmacological research as well. You guys all know how these mechanisms of CNS metastasis, that the dissemination routes, hematogenic direct extension, migration, or even iatrogenic seeding, as commonly we see this in posterior fossa surgery. And but basically, when we talk about physiopathogenic of brain metastasis, we all know the seed and soil and the BBB concept, the blood-brain barrier, that are limiting treatment options, but things are changing, and we are going to show you how. So even the seed and soil theory are updated. We have this new adaptation of the lesion in the brain microenvironment with micro and macro metastasis, and how does it develop it and follow the traditional oncogenical process in the brain. We know that this is all genetic modulated mainly by the STAT3, and basically the metastasis can seed, can soil, but can grow into the brain, become invisible from the immunomodulation, and the T-cell army cannot recognize, and all immunomarkers cannot recognize this lesion as a foreign brain that doesn't, it's not a part of the brain and should be destroyed. But with this new trends of treatment in target therapy and immunotherapy as well, these lesions are becoming more visible and definitely more treatable than we are used with. When you talk about this stratification, for many years, I've been working with brain metastasis since my fellowship at MD Anderson 20 years ago. And we are used to use the RTOG, RPA, the Gaspar publication, dividing this lesion in class 1, 2, and 3. Even now, when you look at some publications, RPA are continues using as one good stratification and prognostic factor, and still using. But we can see that definitely we have some kind of old trend, and people used to treat these lesions based on RPA, like patients with good RPA, I mean 1 and 2 are supposed to be good candidates for surgery up front, and patients with any RPA supposed to be good candidates for some kind of a radiotherapical treatment like a radiosurgery or whole brain radiation. But we are seeing that things are changing nowadays. After that, we have this good JPA, the RTOG, new, the Sperduto publication, dividing by histology. And then you can see some prognostic factors for small cell and non-small cell cancer, carcinomas, melanomas, breast, renal cell, and GI cancers. But when you look carefully to it now, this is diagnostic, specific, but this is not so far very updated. It's outdated. And then when we even check this new tool that Dr. Sperduto provided to us, that the brainmetgpa.com, that we use it to access easily from our cell phones, we can see the main GPA index, and you can stratify these patients. But when it might be uploaded as well. Now, when you talk about lung cancer, we have EGFR, ALK positive or negative, but we have now new markers, and very important ones with a good targetable treatment option as well. So even the brain meta GPA should be updated every 3 or 6 months, because things are changing really fast nowadays regarding this kind of pathology. When you talk about the molecular classification and their clinical implication, this is very important. So this is the main difference and probably a landmark important tool and important information and knowledge that should be applied for all patients. Now we cannot use only the name of the disease, the histology. We should always look for the surname, for the genetical and molecular identity for each histology, and this is very important. This is very important also for the incidence from diagnosis or during the disease. For each histology, you can have like a high incidence of brain mets at diagnosis, or we can expect it during treatment a high number of brain mets. So you can deal with for each patient, depending on the surname, depending on the genetic and molecular identity, our expectations to the brain. All these targetable oncogenic drivers are important. So we have EGFR, we have ALK, we have MET, we have HER2, we have ROS, BRAF for melanomas, we have RET, we have NTRK, and this is very important because we have a lot of good NTRK inhibitors. We have a MEK. And if we check the phase and the science based on for each one, we have a lot of approved drugs that are targetable, but we are still learning how each of them are affecting the brain. This is very important because we have this excellent targetable checkpoint or targetable oncogenic driver with a good selection of treatment option clinically, but how does it work to the brain is so far not clear. And this is the changing that we are noticing in the last couple of years. The beginning, the pharmacological industry just avoid to include our patients with brain mets in any kind of protocol. They are excluded. No, oh, this is a brain met, let's take it out. Now they're looking to the brain basically because we have a higher incidence of the disease into the brain during the patient's life, and patients surviving more and more. And definitely the industry are now looking, the pharmacological industry now are looking very carefully to the brain. And this is interesting for us because this is changing our concept, how we look at solitary or oligometastatic to the brain or multiple brain metastases, and for us neurosurgeons, how we should deal with it in this new molecular and genetic era. So a few years ago, when if I'm presenting this lecture, definitely chemo supposed to not be part of it. And now, based on all these oncogenic drivers, we have a lot of target therapy that could be good results, treatment to the brain, focusing in GFR, ALK, HER2, BRAF, KRAS, PD-L1, and tyrosine kinase inhibitors, and the immunotherapy as well. And immunotherapy definitely is being up to date and changing and creating new paradigms that we are going to discuss. This is just an example in this Sperduto publication that depending on the surname, we expected a long-term survival for patients, even with a terrible disease like lung cancer. We have specific drugs that changing the perspective to treat this kind of patient. And as I mentioned before, the ALK and NGFR are targetable places. And when we talk about lung cancer, definitely this should be addressed and discussed with the multidisciplinary team. For my whole life, I've been working with this. This is the classic 1990 Petchel publication that for a single brain met, we should, or the best treatment option is surgery followed by whole brain radiation. I think most of you guys learned the neurosurgery like this, and this is our traditional trend of treatment. But when we look for a new flow chart of a lung cancer, surgery is not the big player anymore. We can see the first question that we should address is this patient present any kind of driver mutation, yes or no? If yes, is that a targetable? Is there any protocol that can address, and how each of that drugs that I mentioned before could affect CNS? And after that, if you have any issue regarding any lesion, especially, then you can have surgery or maybe a radiotherapy strategy like radiosurgery or whole brain radiation. For no driver mutation as well, even we discuss a systemic therapy, but for symptomatic patients, surgery is still a good player and maybe a big player to deal with this disease. This is just to highlight the importance that our traditional treatment direction, like, oh, this is a single mets, let's do surgery followed by whole brain radiation, is not anymore so important as used to be. When I talk melanoma, we have this BRAF TKIs drugs with a very good response rate, almost 40%. And this is just to also highlight that for almost all brain metastases in a high CNS tropism, you have a name and a surname as well. So when we talk about melanoma, is there a BRAF mutated melanoma? This is the main question that we should address before discuss any kind of treatment options. If not, if you don't have this kind of option, we should look carefully. And how about immunotherapy? Is this patient immunocandidated? Is there any drug that can help the disease systemically and into the brain as well? This is a complex slide for a neurosurgeon. We are used to find ourselves trying to location the Sylvian Fisher, not trying to understand a graphic like this, but basically, is just to highlight that the tumor cell should present some kind of checkpoints in the cell surface, like a PD-L1 or CTLA-4, and with all this connection, recruiting dendritic cells, macrophages, and if you combine together and make this tumor cell visible, as I mentioned before, you might have the recruit of the T killers army and destroy the tumor. This is an example. A few years ago, an oncologist just called me, oh, can you help me with this patient? I have this melanoma patient with 3 or 4 brain mets, one of them around 3 centimeters with some kind of brain edema, and he asked me to take it out. And then I look at this PET scan and say, are you sure? Look at this disease, it's everywhere. Why should I, address and operate this brain, and how should I affect the outcome of this patient? No, this is immunocandidated, and we are going to start a new immunoprotocol with some anti-PD-1 and PD-L1 drug. And okay, let's do it. Let's do the surgery. It's not a big deal for us. And surprisingly, after 3 months of this immunotherapy, in a combined strategy with a CTLA-4 and a PD-1 anti-drug, we have this kind of result. And where's the disease? The disease just disappeared. And then we should realize, and how about the brain? Can the disease disappear at the brain as well? And then we started all this discussion all over the world about the effect of these new strategies into the brain. And for us, neurosurgeons and radio-oncologists, definitely our best friends, the steroids, is a big villain. Surgery has the benefit when you operated a guy with some kind of edema related to a brain met, when you take it out, you can drop off your steroids as soon as possible. Maybe in 1 or 2 weeks, your patient is totally totally withdraw your steroids. On the other hand, when you use to do like a radiosurgery for a brain lesion located in an eloquent area, you might have some problems with steroids. And as we are going to discuss further on, we are expecting these patients to live longer, and radiosurgery has a progressive failure rate over the years, and this failure are related with steroids as well, any time of this disease progression. So this is something that we should consider. So should we need to put our patients off steroids? Oh yeah, so surgery is the big player so far. Oh, steroids is not a big problem, we have small lesions. Okay, radiosurgery is an excellent tool. This is clearly, in the last years, we can see that the patients that are used to use in a long-term steroids during their diseases in the brain, they live shorter than patients that are not using steroids up front. We have a significant difference for progression-free survival and overall survival regarding steroids as well. And when you talk about this steroids, maybe if we have a local control with not surgery, but maybe radiosurgery, we might have some kind of exposure of antigens, and maybe we should become this patient more immunofavorable for treatment. And this is the new trend as well. Most of these immunocandidates, they have a good symbiosis and synergies between radiosurgery and immunotherapy. So immunotherapy and target therapy are not replacing surgery or radiosurgery as well. Indeed, we are trying to find the role of each one combined together. And clearly, we are also understanding better these new treatment options. We just the neuro-oncological community just realized that a single agent immunotherapy, they tend to be effective, but if you combine two modalities and strategies of immunomodulators, you have a significant results and good results regarding progression-free survival and overall survival and local control and distant control into the brain. This is a typical example. In the right side, we have a carcinomatosis, a meningeal carcinomatosis. The disease is all over. This is a melanoma without the BRAF mutation, and I started the combination of a two immunomodulator, and this is after 1 year of this strategy, there is no disease into the brain. We are talking about carcinomatosis and meningeal. This is a terrible disease. We are used to have like a 4 to 6 months of survival for this patient, and now we are talking about a long-term survival. So, and then we have to realize that maybe we can offer more than our traditional Ommaya with intraventricular injection of some kind of chemotherapy to these patients. Finally, we are all surgeons, and definitely surgery is trying to find its way into all these new concepts. And is there a rule of surgery? Definitely yes, still yes, and we're going to discuss some of them. We respected all the traditional neurosurgical oncological concepts of accessibility, resecability, and quality of life. We used to have all these surgical criteria, that size, location, histology, age, KPS, and general condition. We are all worried about, oh, this is an oncological patient, he's not in a good shape, maybe he's not a good surgical candidate, and how is the primary status of the disease. But now, definitely we should include it as well, as I mentioned before, this kind of if the patient is immuno or targetable treatment candidate. But even following these criteria, we have some situations. And the main issue when we are talking about brain metastasis, this is not a single physician patient. It's crucial to have a multidisciplinary discussion and use as a neurosurgeon should apply your common sense and not be focused only in protocols. This is an example. Oh, this is a patient with a huge posterior fossa melanoma metastasis with a KPS of 60. If you follow the tradition or the old trend, oh, this is a lower than it's a KPS below 70, it's 60, and has a intracranial hypertension, is not a good candidate for surgery. But clearly, if you remove this lesion, as we did it after second day, the patient improved his KPS for 90. Let's move to the extreme situation. This is another melanoma patient. The disease is totally under control below the neck and has this bleeding in the right insula. And then I had this call, emergency call. The patient is an isochoric and a KPS of 10. Okay, game over. Let's, bury this patient. Unfortunately, we cannot offer. Is that the right thing to do? Let's talk. This is like a bleeding, critical situation for us neurosurgeons. I'm sure if this patient is not an oncological one, you guys are going to operate it. So let's call to the oncology and understand the disease and see if this patient has some kind of good perspectives in this new molecular era. And the patient, yes, indeed he had. So let's do it like emergency surgery, and the patient recover his KPS for 70 after 7 days of surgery. So this traditional protocols about a low KPS or aging as well, like a patient's over 70 years, let's do nothing. This is not only, and we not should apply isolated all these criteria. Let's, for each patient, have their multidisciplinary discussion, trying to find the best treatment option for each patient. Coming back to the case that I presented before, the patient with a 12 melanoma lesions, it's a negative, BRAF negative, some of them with edema. We decided to operate the edema ones, even the smaller ones, because this patient was immunocandidated. This is after removing 6 lesions that were causing edema in 2 crannies, and the patient received EP and NIVO, and after 30 days, whole brain radiation. This is the patient over 1 year after treatment. There's no disease into the brain. And then we just highlighted that, oh, indeed we did a good thing, looking retrospectively. But if I just showing to us the first panel of diseases, you can just argue with me that, oh, this is not a surgical patient. And maybe you're right, we never know. But in this case, in this context of immunocandidated, was a good option. We have all these surgical tools, but I'd like to highlight the navigation, the ultrasound, the intraoperative MRI. Ultrasound for me is a big player and maybe is the main tool. Why is that? Because it's easy, it's cheap, it's available in all OR by law in Brazil, because the anesthesiology might function vessels guided by ultrasound over here and probably all over the world. It helped you finding the lesion location, helped you in the surgical strategy, helped you in the differentiation of edema and lesion, and even after resection, the residual tumor. This is an example that I mentioned before. This is a small lesion that you might have some difficulty to find it. You have the brain shift, the navigation could let you go in the wrong way, do this, the brain shift, and then you can use the ultrasound and help you used to help you in your surgical strategy, trying to achieve an en bloc resection, even for small lesions like I just mentioned to you. This is another example of this lesion in the motor sensory area and a small craniotomy. So neuronavigation is very good for this tailor-read cranies. And this is important for oncological patient because we should discharge this patient soon from hospital, and he should be able to start his treatment as soon as possible. So tailor-read craniotomies are very interesting, but should be enough for you to do your intraoperative monitoring. In this case, the ultrasound, we had the lesion, and we are not sure if the lesion is at the motor or of the sensory, but you can see in the middle of the ultrasound the central sulcus. And then we decided going up front, going backwards. You can see the fissure, the central sulcus in the middle of the lesion, and we decided to do a resection in two parts. The anterior part, the pile resection, anterior and posterior, trying to avoid coagulations of the main vessels, the main truck vessels that used to run into the pile in the central sulcus. And this is after resection. You can use any strategy that you are using. You can do like a transsulcal resection to an en bloc resection, a transcortical one, a trans fissure, Sylvian fissures, or transsulcal, depending on your strategy. And just to mention that your craniotomy should be as big as enough or tailor-read and tailor-read for you to do intraoperative monitoring. Regarding intraoperative monitoring, we should apply a continuous intraoperative monitoring. Not only identify where is motor, where is sensory, where is the tract, but doing the resection, especially when you are doing like an en bloc resection, dissected with your probe. Now we have this kind of probe that is pretty much like a pain field, and then you have a real-time intraoperative monitoring, or use the suction probe when you are resecting and suction at the surrounding glial tissue. This is an example of this lesion in the motor strip, and use this technique, you have a very good outcome for the patient. In our experience that we published before, for lesions located in an eloquent brain, we have over 185 patients. And unfortunately, for these locations in eloquent brain, we have only less than 50% of en bloc resection, and I'm going to show you why this is important. But we also have a complication rate of 15%. Let's keep this number in mind because we are going to compare with radiosurgery further on. This is a case that didn't work well. I could not reach this lesion without impair the patient. I have some kind of positive testing for many nuclei when I'm trying to reach the lesion into this patient. Was treated before with radiosurgery twice, and I have some difficulties to reach this lesion, and the patient after resection presented a worseness, a clinical worseness, a neurological worseness after surgery. But when we look carefully to the literature, we can see that we have a few complications and overall complications followed by a craniotomy for brain mets. We have this kind of concern that this is a critical patient because it's an oncological patient, but when you are looking for pneumonia, VTI, or urinary tract infection and sepsis and so on, we have a low rates, fortunately. But in one situation, I would like to highlight the importance of location. And infratentorial tumors are related with a long extent of stay and reoperation rates and readmissions and fistulas and neurological problems, and mainly to the secondary or carcinomatosis, meningeal carcinomatosis for these patients. So factors that affect the local recurrence, definitely size. The histology sarcoma, that is the only one that might have some kind of brain invaseness, not only extra brain disease, and patients that did not receive en bloc resections. So the surgical technique is very important, mainly trying to avoid the leptomeningeal disease and the local recurrence, and definitely your en bloc resection is critical to avoid this kind of a situation. I mentioned before that carcinomatosis and leptomeningeal disease are a terrible progression of the brain cancer, and usually related with a low survival rates. But if you are dealing with lesions at the posterior fossa, you have an annual risk of up to 25. And if you are operated patients over there, definitely you should take care about your surgical strategy. I mean, pre and post-op, we are going to mention that further on. This is another interesting MD Anderson paper. But if I achieve en bloc resection, why should I submit my patient to a complementary or adjuvant radiotherapy, radiosurgery for surgical cavity, or even whole brain radiation? Indeed, if you add some radiotherapy for your patient after surgery, like Petcho mentioned before in 1990, you have a good or better results for local and distant failure, that's for sure. But MD Anderson, so far, they tend to not apply immediately after surgery an en bloc, clearly en bloc resection, any sort of radiotherapy after surgery. And this is interesting and maybe should be considered as well. For multiple brain mets, you can do simultaneous tailored craniotomies, or even in one craniotomy, you can address many lesions as that you wish. This is another example, but we just keep in mind that for each craniotomy, we have around 80% of complication. So if you'd like to do like a 5 or 6 crannies, probably your patient are gonna have some kind of problem in the post-operative evolution. Regarding the posterior fossa, as I mentioned before, we should look carefully for this patient. This is a very interesting retrospective study at MD Anderson comparing piecemeal resection, en bloc resection, and radiosurgery. And definitely the piecemeal resection were significantly related with leptomeningeal disease after the treatment. This is the classic en bloc resection that should be addressed. And considering that, we are going to discuss a combined local treatment surgery for radiosurgery after surgery, or radiosurgery prior surgery. And this is a specific situation that, in my point of view, should be that definitely fit well for this kind of patient, to do pre-operative radiosurgery for posterior fossa lesions, but we're going to mention this afterwards. So for the impact of surgery, definitely we have this relation with rapid steroids drop-off, fast neurological recovery, easy radiological interpretation. This is very interesting because now we are dealing with all these new treatment strategies like immunotherapy and target therapy, and we have to do these renal criteria and have our interpretation of these results. Most of these patients used to present some kind of increase in size, like inflammatory burden related to treatment, but we are still trying to understand this radiological interpretation. But if you don't have lesion, like previously removed with surgery, it's easy to understand this kind of radiological interpretation. And after surgery, it's easy to have a proper brain management for our patients. We have some additional criteria that recently are highlighting, like gliomas, that the new gene sequences are becoming more and more important, and maybe you should reoperate your patient to get some samples for patients with glioma, and then you can have this new gene sequences and upgrade your treatment for brain mets. And I'd like to mention that Dr. Brastianos from Boston, she spent her whole life studying this kind of patients, just presented to us nice papers that most of over 50% of these patients have a different the same histology, but in a different marker, a different biomarker, a different gene or important molecular driver, and you can change your treatment based on this new biopsy. So maybe in the near future, the new molecular and you might have a new molecular and genetic diagnosis when the disease reach the brain, even if you have like a prior primary diagnosis at the lung or breast or whatever. We have this new strategies. I mean, LEAT, I have absolutely no experience, and this is my good friend Sujit and Diego, good friends that are doing a great job with this new strategy. Maybe our panelists can help me explaining better this kind of thermal burning disease strategy, like a LEAT, that you have this thermal control. But this is also interesting for radionecrosis as well, not only progression after radiosurgery or upfront, but I've been seeing specific tricky locations treated with LEAT with good results, and this is interesting, like this thalamic lesion or brain stem lesion, like that one that I mentioned before, and I impair my patient after my surgery, and maybe LEAT should be a good tool for these patients. Regarding radiotherapy, for many years, these are two Brazilians that they are UFC fighters. UFC in Brazil after soccer is becoming the most popular sport. We have a lot of Brazilian practicing this gentle sports called MMA. And for many years, we've been fighting with radio oncologists, trying to prove that surgery is better than radiosurgery. Then they were trying to prove that radiosurgery were better than surgery. I was part of this process during my career. I've been doing like a meta-analysis and publishing some papers, and for sure in all this retrospective, not level 1 science-based medicine, we have this papers that suggest that the surgery is better, others that the radiosurgery is better, others that they are similar. But we have a trend, this is the MD Anderson number, that people are operating less and treating more patients with radiosurgery. This is a fact. I can notice this in my clinic, and maybe you guys can notice in your clinic, that definitely radiosurgery is effective, and it's increasing in number comparing with surgery. When we compare the beginning of radiosurgery, most of patients used to be treated with surgery, and now most of patients are treated with radiosurgery. The real effectiveness and complications rate, this is important. This is some of our publications, but we noticed that in our multivariated analysis regarding outcome and location, that the primary status, if the lesion is located in a functional eloquent brain area, and volume for sure, these are positive factors that are significant for failure in radiosurgery. Talking about complication rate for lesions located in eloquent areas like motor, sensory, brainstem, and speech areas, we have a complication rate of 22%. Coming back to my series, a surgical series, we had this complication rate of 15%. So the traditional trend, oh, the lesion is located in the motor, let's do radiosurgery. Probably you might put your patient in a higher risk. Depending on the size, depending on how deep your lesion is, maybe surgery should be, especially regarding this fast steroids drop-off, surgery should be a good option, even in lesions located in eloquent brain. We also published that the radionecrosis is only radionecrosis in 1/3 of patients. The rest of them are a mix of treatment affected and even disease progression. So when you're doing like a pathological analysis of after removal of this patient. So when we see like a radionecrosis, we might have this in mind that maybe you are dealing with a truly progression of the disease. And we might have this concept that radiosurgery is definitely effective for all histologies, mainly at the first year. But this effectiveness is, you have this decreasing rate of effectiveness during the long or during the life of the patient, especially after 1 year. So if you have a patient that might, or you expected for him to live longer, maybe you should consider surgery as your main or your current treatment option at that time for that patient, especially because of this, the fast steroids drop off. But this is again the MD Anderson series that people can do an MRI easier and easier. If you have any complaint, okay, let's redo MRI, and you are treating smaller and smaller lesions with radiosurgery. And this is good. You have a local control as soon as possible. The disease is just diagnosed. Regarding size, this is a critical issue as well. For the last 15 years, I used to have this concept of this magic number of 3 centimeters. Okay, it's bigger than 3 centimeters. Let's do surgery. Oh, okay, it's smaller than 3 centimeters. Let's do radiosurgery. This is the concept that I learned. But when we look carefully for this shown, the RTOG toxicity grade 3 and 4, and we compare size, we have these big groups of up to 2 centimeters. You have like a 10% of complications. Between 2 and 3, we have, depending on the dose, maybe 25% of complication, and over 3 centimeters, depending on the dose, 15 to 33. So why 3 centimeters is the magic number? How about the 2.9? How about 3.1? And these big groups. And for me, there is no huge difference between these two groups of 2 to 3 and over 3. And when you look for the new publications regarding size, the smaller lesions definitely has a great outcome in local control treated with radiosurgery. So in my point of view, we should just forgive and forget all these 3 centimeters magic number and treat smaller lesions with radiosurgery. As I mentioned before, it can fail, and the fail in long-term follow-up of this patient is over 30% with radiosurgery. But as I mentioned, I was trying to prove that surgery might be superior than radiosurgery. And then we realized that we are friends. We should work together. Why not operated bigger lesions and do radiosurgery for smaller? Or why not combine radiosurgery after surgery, doing like a surgical cavity? And this is the new or the recent trend that we are dealing with. I mentioned about immunotherapy, and radiosurgery definitely has this kind of a peculiar aspect, the abscopal effect. If you treat one lesion with radiosurgery and then you do immunotherapy, basically by maybe presenting some new antigens and the disease into the brain for new lesions or other lesions not treated, the lesions shrink. So we definitely have this synergistic effect with radiotherapy and immunotherapy, and this should be considered nowadays as well. But we have this problem of timing. What you should do first? They ask your opinion. We have a lesion into the brain. Oh, let's do radiosurgery and then start immuno. Oh, let's start immuno and then do radiosurgery. Let's operate it and then do. We are still. This is still unclear for us, the precise timing for upfront treatment. If we should start with surgery, with radiosurgery, with some kind of a target therapy or immunotherapy as well. And this is how science is basically defining our near future regarding our upfront strategy to how to treat brain mets. There is no limit nowadays to treat regarding numbers with radiosurgery. We have this old concept of up to 4 lesions radiosurgery, over 4 lesions, let's do whole brain radiations. After this classic Yamamoto publication comparing 10 lesions and oligometastatic disease, we have a very good results. I've been presenting lectures all over the world, and I'm surprised that I'm seeing like 75 lesions treated with radiosurgery, 50 something, 60 something. So it's clearly there is no magic limited number for all of these patients. So radiosurgery is very good for local control. This is an outpatient treatment. It's a low acute morbidity, minimal invasive concept. This is you have this new trend of combining radiosurgery with a new strategic immuno or targetable treatment, but we still have differences in effectiveness and complications rates regarding location, size, and the primary disease as well. And the recent trend of a surgical cavity as well, it's interesting, it's elegant, and you avoid whole brain radiation. This is retrospective studies like a meta-analysis, and when you look carefully for local recurrence with this strategy, radiosurgery as following surgery, we have this local recurrence between 5 to 25%. But when we come back to the classic Patcho publications or other publications following surgery and whole brain radiation, we have similar numbers. So radiosurgery followed to surgical cavity compared with whole brain radiations, you have similar numbers, but the effect of whole brain radiation, you might have a better long-term follow-up outcomes. This is the Paul Brown publication, and it's very interesting that comparing at 3, 6, and 12 months, if you treated these patients for local and distant control with a whole brain radiation, it's still on. So we are trying to avoid whole brain radiation, but this is still good tool. It's a good treatment option so far when we compare outcomes. But when we compare quality of life and neurocognitive status, definitely we might have some problems. Whole brain radiation are or used to be associated with bad neurocognitive outcomes and a clinical decline of patients when we compare with radiosurgery. But this is another interesting Paul Brown slide that he just presented at this SNO meeting. That why should this patient present this kind of neurocognitive deficits? Is that only whole brain radiation fault, or you might have some kind of tumor location and progression, other complications that regarding cancer, like medications, depression, epilepsy, infections, and so on. And if you apply some kind of neuroprotective tools, I mean, memantine and hippocampus spare, I mean, you might have a good results as we have with radiosurgery to the surgical cavity. But we have this new current trend. Why not use radiosurgery prior to your surgery? And this is simple, but why should we apply this new concept of pre-op radiosurgery? Comparing the two main complications regarding radiosurgery followed surgery, we have a high number of leptomeningeal disease and radionecrosis. You can imagine that you have like a surgical burden with a lot of hemostasis and coagulation, and then you are going to do 20 grays to this area that is suffering from your surgery as well. So doing a prior radiosurgery to your surgery, you have better results regarding meningeal carcinomatosis and radionecrosis as well. So this is, in my point of view, our current trend. And regarding our concern about lesions located in posterior fossa, maybe this should be a good strategy. Even if you have like a 3 centimeters or big lesion in posterior fossa, if we apply this pre-op combined treatment strategy, you might have a lower rate of carcinomatosis. So for us in our group, we have 2 cases so far. It's not a big series because we are just applying this technique for posterior fossa lesions. We are doing pre-op radiosurgery to our patients. This is an example. Imagine as well for a radio-oncologist, for him it's really easy to do the radiosurgical planning for a lesion like this. You can draw this in 5 minutes. Oh, the lesion is here. Let's do our plan and let's apply 20, 22 grays, even a higher doses, because after 5 to 7 days, I'm gonna remove it. On the other hand, if I have all this surgical cavity with some kind of swelling and some kind of hematic Surgicel or something, and the brain is a kind of collapsing, to do the precise surgical cavity treatment is not as good as doing in a situation like this. That makes sense, that become easier to the radio-oncologist to treat a lesion than a surgical cavity as well. I unfortunately have only a 14 cases experience, but in my point of view, it seems to be a good option to treat this patient with this combined pre-op radiosurgery strategy. Many years ago, I published in some books, this is in Portuguese, a kind of a flow chart treatment, and then I realized that I'm a dumbass, because after 2 years, it's worthless. It's completely different because thinkings are changing in the neuro-oncological point of view for brain mets, and we might have this concept. Even if we trying to ask to our friends from NCCN guidelines from 2012 until now, if you have a resecable lesion, you can apply surgery, or you can apply radiosurgery, or you can apply one followed by the other, or you can apply whole brain radiation after or before, whatever. You can do whatever you want. So you don't have like a specific treatment. That's the importance. This is just to highlight the importance to do multidisciplinary approach for your patients. We don't have a flow chart, but we have this kind of directions that we establish in our group, that for all cases, we try to do a multidisciplinary approach and think as a neurosurgeon about maybe this patient is an immuno or target candidated. Lesions smaller than 1.5 centimeters, we have a trend to do radiosurgery, bigger to do surgery. En bloc resection, we maybe we can use or not radiosurgery, but now we are applying a pre-op radiosurgery to all patients. Piecemeal resection, just make in mind that your patient must receive any kind of radiotherapy after your surgery. So the type of surgery is critical for you to deal with the disease in a multidisciplinary approach. For posterior fossa tumors, we might discuss the variable of whole brain radiation, but in my point of view, we might do some kind of a pre-op radiosurgery. And maybe, I don't have the experience so far because I just applied for 2 cases, we might have a lower rate of leptomeningeal disease for these patients. And put in mind that despite the fact that how we treated the brain, the primary status will define the outcome of our patient. If the disease is progression, we kind of a sort of treatment, we are going to have problems into the brain as well, despite the way that you treat your patients. We should stratify, understand the histology, and name and surname of the disease. We can apply the personal treatment, I mean precision, individual treatment for our patients, and not only trend medicine. Oh, let's do this. This is interesting. Let's try to not follow protocols, but understand each patient and which treatment options will fit better to each patient. Surgery is still safe and is still a good option, and our goal in our surgery should be an en-bloc resection. Unfortunately, for lesions located in the eloquent brain, it might not be feasible. Always put in mind that your patient might be a immuno or target therapy candidated, and always apply a multidisciplinary approach for a brain met patient. This is us looking to the brain, but not anymore. We should understand the disease and understand as well that we should not deal alone. We are not on, we not on the patient. This is a multidisciplinary patient, and we are still an important part of this team work dealing with this brain mets disease. Thank you for your attention.
Thank you so much. That was really one of the most comprehensive talks on brain mets that I think I've heard in a long time. So that was really outstanding. I know you went a little over time, but it was really, really important information, I felt. Just a couple of questions that we have here. One question from the audience is tumors that are dural based, and you're trying to understand if they're meningiomas or metastasis, they have a history of maybe of cancer. What is your strategy for both kind of preoperative imaging and also for surgery?
So first, we should realize that we might have a dural-based metastasis, and this might not be a carcinomatosis. And this is the first issue. And we should apply like dural resection as well, if it's feasible. If it's not feasible, like skull-based, dural-based metastasis, we should complement the whole dura into the radiation after surgery treatment. So this is the first issue. As you mentioned before, the traditional MRI should be done and focus in this dural analysis, but your patient might receive a pre-op CSF analysis as well. Because if it's possible, you might do surgery, but your patient might receive whole brain radiation after treatment. So if you have this, I'm not sure if this is a dural-based metastasis or even a carcinomatosis with a lesion specific in one area, you must do a CSF prior to your surgery, and then define with your multidisciplinary team the best approach for this patient.
Great. One question I had is, following up on Dr. Braciano's work with this idea that some of the mutation statuses are different intracranially than they are in the body. Do you think there's going to be a time where we will need to be biopsying maybe tumors that are resistant, just to find out, again, even if somebody had multiple mets in the brain, to biopsy just to get their kind of molecular profile to see if there's another agent that maybe we haven't tried yet.
This is an important question. The numbers are high. We are talking about over 50% of surname differences. It's the same histology, but it's probably a different truncal, clonal cancer that are developing. So you just selected the patient after some prior treatment. Oh, he received like a specific EGFR drug. Okay, good. And now we have recurrence. This is the main question. Why this is just fail? Probably it's a new, clonal cells, and so I totally agree with you. We might discuss to biopsy or remove this lesion to have a new sample and just check if we are dealing with the same disease based in different surname.
Yeah, no, I agree. I mean, I think in the past, a lot of us have blamed the blood-brain barrier and penetrance for why things are not working in the brain. But I think this brings a whole new concept as to different kind of mutations that may be happening. I know we have our panelists, and I know they're busy, so I want to get to their cases next. So maybe Dr. Rodriguez, if you want to start.
Sure, absolutely. Let me go ahead and share my screen. I want to thank Dr. Muldoon for such a wonderful talk, and to also emphasize how surgery isn't going away. And similar to making an MMA reference, I grew up watching the Gracie brothers. So think kind of surgery is kind of like them. It's just not going to go away. It's a classic. So that's kind of what I took away from your talk. So let me switch this. All right. So my patient is a 60-year-old female who presented 2 years after her initial diagnosis. She had melanoma, and she had a local excision of a back lesion. The margins and lymph nodes were negative, and she did not receive any adjuvant therapy. But she came in with headaches and confusion, as well as just difficulty completing tasks at work. She's actually a cook, and she just couldn't remember how to do things. And now on exam, she had some mild left-sided weakness. So I'll just go ahead and show the imaging. This is her MRI on presentation. So here we see that she ends up having a total of 15 lesions, with the largest in the right insula/basal ganglia, and then the second largest being near the splenium. So again, 15 total lesions, and I don't know if we want any input on what Dr. Muldoon would do, but I guess we'll wait till after presenting this case. But we ended up taking out the largest lesion. So I talked to the radiation oncology team. I felt that she was symptomatic, obviously, and elected to take out her largest lesion. And I ended up using the brain path device. I really like those for deep lesions. So I did a transfocal approach and kind of mapped out her tracks and was able to get a complete resection. And then we follow this up within a week. We ended up doing SRS to each of the remaining lesions, as well as to the cavity. So each of the smaller lesions got about 20 gray, and then we fractionated the resection cavity, and that splenium lesion got 3 fractions of 9 gray each. So again, this is just showing the post-op films. And then she was mutated. She had a BRAF mutation, started on BRAF and MEK inhibition. And this is her a year later. Approximately 9 months later, she had some areas of recurrence that were treated with SRS. This is her a year later. Thankfully, this lesion back there actually responded to SRS. So I don't know if we wanted to get Dr. Muldone's insights or.
Yeah, for sure. That was a great outcome.
Indeed, I just would like to thank you because you just resumed my talk in 2 minutes.
You're welcome.
So this is the main issue. So we have to work together. So we have your radio oncologist concerned about that big lesion size, but indeed your patient is a target candidate for BRAF and inhibitors and MEK inhibitors, as you mentioned before, with a very good brain result. Even if your patient is not a BRAF mutated patient, your patient might receive immunotherapy, and then your surgery is definitely feasible as well, just to make him steroids free. So you just manage perfectly your case, and putting all together all this new concept for us neurosurgery. This is how a patient should be addressed in a multidisciplinary. It's interesting because they still have like more than 10 lesions, and was treated with a radiosurgery. Just this is interesting. We can see the abscopal effect of target therapy with radiosurgery. We can just trying to understand the oncogenetical features and radiobiological features of radiosurgery. You just present some kind of antigens and cytokines of interleucins in that microenvironment, and make this lesion treatable. And then you have like a distant response or good response in lesions not treated. But this is a very good example that summarizes everything that I've talked in one hour. Thank you.
Yeah, excellent. I mean, I think a lot of times these melanoma patients, when they present with a large lesion with many others, it's because one of them bled. So this was a little bit unusual because you had one that looked solid, and that's a hard tumor to take out. So congratulations, it's a great job. And I think that just understates what Dr. Muldoon is saying, is that the number of tumors isn't necessarily as important as kind of the size and all the other features of the patient, and treat the patient, not just the image. Brian, do you want to go next?
Sure. So my patient's a 58-year-old gentleman with, like many people in Kentucky, a long history of smoking, presented with right-sided hemiparesis or left-sided hemiparesis and hemisensory disturbance, originally in 2016, and had a solitary lesion found. He has a history of T2N0, M0, lung cancer, adenocarcinoma, ALK negative, EGFR negative, that was diagnosed about 4 years prior, and he'd just been under surveillance. He never had chemotherapy. And so with the solitary met, we're still living in Patchell's world. So at the time, the lesion was resected and got postoperative radiosurgery, and then was observed. No further metastases were noted. The CT of the body at the time of this image over here was negative. There was no other distant metastasis in the body. So still under surveillance, no chemotherapy. And then when I took over his care, he came back and had recurrence at the same site. Again, his body imaging was negative. Again, the rest of his brain was clear. So he had local recurrence. And at this time, I offered him biopsy laser ablation versus craniotomy. And he elected for biopsy laser ablation, which I thought was very reasonable. And so here's the laser catheter and the tumor, or whatever this was. And there's the 1 month post-op. The biopsy had about 40% active carcinoma. So he got, again, fractionated radiation this time, radiosurgery, I should say, and was followed again. So this is him 2 years later. And he comes back again and still has no disease in his body, still has no disease elsewhere in his brain. But he's had 2 rounds of radiosurgery, and he doesn't have a good systemic option, and the lesion's rather big. So, you know, we can talk about options now, or I can tell you what I did. Either way is fine.
Yeah, let's talk about what everybody would do in this situation. It's a tough case. Maybe Chris, do you want to go first?
Sure. So it's a tough case. You've had 2 surgeries. It's been radiated. You had a lit, but it seems like the lit didn't necessarily respond. So given that he has no systemic disease elsewhere, I think it would be unreasonable to offer him a second open surgery since he only had 1 open surgery.
Dr. Rodriguez?
Yes, I definitely think surgery, especially given how much edema he has. I just see that whole hemisphere has significant edema.
Yeah, no, I agree. I mean, it's definitely higher risk with the radiation being twice and chemotherapy with wound breakdown and whatnot, but he's got obvious significant mass effect. So
Yeah, so I'm in the boat with you guys. I think surgery is pretty good. So I wanted to get back in there. But for me, I thought, you know, this is the post-op scan. So we did went back down the same tract. And you'll notice the radiologist got very happy about the edge of the tumor here. But I thought the local control aspect, which we'd been struggling with obviously on this, was a challenge. And so with burning the bridge of 2 radiosurgeries, our radiation oncologists didn't have a lot of enthusiasm that anything else would be possible. So the one wrinkle we did was we ordered a brachia or a cesium mesh and implanted that at the time. And so we implanted a cesium mesh to try to improve our local control rate afterwards. And he's about 8 weeks out from surgery now, this one that we did here. And he's doing well. His hemiparesis and hemisensor disturbance improved. So surgery still works, but we're not sure if this is going to hold or not. Hopefully it will.
Dr. Muldoon, anything you would have done different there?
No, just the season that I don't have this kind of experience with any kind of wafers or brachytherapy or local, I mean, strategies. We know that some, for cases difficult like this with bad local behavior that are not controlled with traditional surgery, radiosurgery, and radiosurgery and whatever. Maybe this might be a solution. I have absolutely no experience, and I just would like to thank you to highlight the lit importance as well. But you melted the lesion, but it's still aggressive. And I just would like to ask you if this second and third surgery, if you have absolutely predominance of disease, or if you have a lot of treatment. I mean, treatment. How can I say? Treatment effect. I mean, it's a treatment effect, or mainly truly residual disease progression. What do you think? If your pathologist just agreed that it's totally disease progression, or you may have some kind of treatment effect.
Yeah, I mean, so with the lit, the one of the downsides certainly of a biopsy lit approach is that even if you do the biopsy, you still have sampling bias. It's still a core of maybe 1/20th, 1/30th of the tumor, and so there's certainly that can lead you astray. So about 40% of the needle biopsy we did showed active carcinoma. So, you know, for whatever that's worth, that, you know, suggests that there's still active cancer there. With the surgical excision, it was 80% active cancer, and we took out the majority of it. So, you know, I feel like the lesion is coming back from two things. I think, the lit can always be improved a little bit, and I don't always get the best heat spread. And so we had over a 90% ablation of it, which is pretty reasonable with active cancer at that site. My sort of practice bias is to treat with radiosurgery afterwards, especially if it's over a quarter active carcinoma in the biopsy, and go from there. As to why this has come back sort of every 2 to 3 years on sort of like a metronome, that's a separate question. And why hasn't it spread anywhere else if it's so aggressive? That's also a separate question.
It's look like a sarcoma behavior. I mean, you have a huge local recurrence with not sarcoma used to behavior like this. But I've just asked you that because in case that you have a predominance of treatment effect, maybe we should use anti-angiogenic agents like a bevacizumab after your surgery, instead to use the cesium that I have no experience, and hopefully you're going to work. And so if you have this predominance of treatment effect, we might consider in the use of bevacizumab or other anti-angiogenic options.
Thank you.
The only thing else too, I would say, Brian, is the lit isn't like radiosurgery, and we could, here we've done, we have a pretty large series of over 120 brain tumors, and of those, I think we're up to now 7 patients that we've retreated after it's regrown. So treated with lit, again, had a very good ablation, like you said, and then a year and a half later, you have the small recurrence, and we've gone back in there and just did a second lit when it was small. Obviously, here it cat's out of the bag. But if a patient has good follow-up and they're able to kind of get frequent scans, sometimes you could touch up with the lit coming from a separate trajectory. I don't know if you have experienced that at all as well.
Yeah, I have a reasonable experience with staged lit, and the golden question is, for you or for us, is getting it at the right time, and then is it staged in terms of planned, 2-stage lit at the outset versus a follow-up and watch and see approach. And that part I haven't well worked out for myself yet when I don't get a perfect ablation, but I'm working on it.
Okay, thanks again. A great outcome so far. Chris?
Yep. So thank you so much, Dr. Maldonado. It was a fantastic talk, and glad to be back with the Miami Global Symposium team. As Mike mentioned, I completed my fellowship there in neurosurgical oncology last year in 2019. So we'll finish this off with a nice case here. It's a patient, 63 years old. She was diagnosed with stage 4 invasive ductal carcinoma of the right breast, status post modified radical mastectomy and adjuvant chemoradiation. We had the importance of multidisciplinary approaches. Dr. Maldonado mentioned we had an oncologist and radiation oncologist and myself in the tumor board, and they referred this patient to me with sharp throbbing, constant headache, and dizziness. Neurologically, she was intact. On the MRI, we could not get a contrast scan due to her kidney disease, so it's a non-contrast scan that shows a 1.5 by 1.4 centimeter solitary right frontal brain met just anterior to the motor cortex. So given its location, a couple thoughts came to mind in terms of whether to do this awake versus doing it with cortical mapping with MEPs. And decided to proceed with MEPs and cortical mapping in this case. So we took her for a right frontal craniotomy and tumor resection. We did a hair-sparing linear incision. We marked out the area with navigation. And then with cortical brain mapping using a neurostimulator with 5 milliamplitudes over the cortex, we found no stimulation. And then, as Dr. Maldonado mentioned, using the probe as a dissector through the surgery, we performed an en bloc tumor resection. Frozen came back as metastatic carcinoma, and she tolerated well. She was neuro exam was intact at baseline, and we were able to discharge her from the ICU post-op day 1. And then this was after this case, we performed SRS boost to the cavity 20 grays, and this is a MRI now 9 months post-op with no recurrence, no residual, no recurrence. And one of the things, you know, you mentioned about the SRS, we're also working on a protocol right now to decide, you know, a trial whether to do it pre or post-op, like you mentioned. So that's something we're looking into as well. And
just out of interest, who does a motor cortex MET awake and who does it asleep? Because I've definitely been trained both ways.
I do it awake. I like awake surgery.
I do awake as well.
yeah, I prefer awake as well, but the anesthesia was an issue in our case, so we had to do it asleep with cortical mapping. But I definitely would prefer to do it awake.
Dr. Muldoon, what's your threshold for awake surgery for metastasis?
I'm a very good, fan of awake craniotomies. I have a, good experience for gliomas, but for brain mets, considering that most patients has some kind of a lung involvement and might have some kind of CO2, not well ventilated patients. In that case, if the patients are very good shape, I used to do awake. But on the other hand, considering that this is not an infiltrative tumor, it's not wrong to do only traditional motor SPSS, monitoring. But I used to do awake as well, but I have this kind of concern regarding the lungs.
Got it. Okay, great. Yeah, great case. Nice job, Chris, and good outcome there. Okay, well, we're already over time, so I just want to thank everybody for taking the time out of your busy schedules. I know everybody here is extremely, extremely busy. It was a fantastic talk by Dr. Muldoon and everybody else. Thank you for the cases. I hope everybody stays safe.
Thank you.
Thank you
Thanks,
very
everyone.
much.
All right, take care. Bye.
Be safe, people.